Okay, so again, this is also going to be an interactive presentation, so I hope no one's asleep. Right, so we're going to talk about imaging in paediatric trauma today. So what this will involve is the incidence of paediatric trauma in children, how the injury patterns are different to children, and how guidelines for imaging differ as well. We'll go through this with some cases and then discuss an audit that we've done and summarise. Some of you may have heard this talk before because we're trying to educate as many people as possible. So apologies if you have, but I know some of you haven't either. Okay. Yeah. So this is for the east of England. So 3.4% of all trauma is paediatric trauma. So as you can see, it's quite a small proportion. Not everybody would manage it. And even if you do manage it, it's not something that you would do on a daily basis. So because it's quite rare, people can forget certain things. So this is just a reminder of what you should and shouldn't do. So the injury patterns in blunt trauma are very different to adults. So children have more compliant chests. So whereas adults might fracture ribs, children don't always fracture ribs. And if they do, it means a significant force has happened. They might get pulmonary contusions underlying. Again, they're more common in children compared to adults. Spinal and pelvic injuries are rare. Liver and splenic injuries are common, but they're treated conservatively. Even grade 4 renal lacerations, splenic lacerations, you don't always have to rush the child to theatre unless they're hemodynamically stable. But they do need to be in the correct centre. So you do want these children to be somewhere where you've got paediatric surgeons, which is what we were just discussing in the presentation before. So because children have radiosensitive tissues, the CT cancer risk is significantly higher. So we're going to talk about why you should use the ALARA principle. Okay, yeah, next slide. Okay, so just to remind everyone of the guidelines, the Royal College of Radiology produced some guidelines specific for imaging in paediatric trauma. So at the time, CT was the imaging of choice. There's no role for ultrasound scan at all, and we don't use it in adults for trauma either. We do use fast scans for adults, but extended fast is not used in children because there's not enough evidence to support this. So it's not something that I would be doing as an adjunct in my primary survey. What you can do in your primary surveys are x-rays, so chest x-ray or pelvis x-ray. Again, you need to think about, do you need to do it at the time? Are they helpful? And then when you think I actually need to do a CT, you need to think about which image, which parts to CT. So you're not going to do a full trauma CT like you do in adults. You need to be focused. So if a child needs a CT head and neck, you'll do that. If a child needs an abdomen, you'll do that. You won't just do everything. And then MRI is only reserved for potential spine injury. So remember, some children can get sciura, so it's important to remember this. And MRI is not first line, so these children need to be kept in, followed up, and then have an MRI done as well. And sometimes that is in the ED. So if you've done all your primary survey, you've done your imaging, and you're still worried about the child, you would call MRI that day to organise scan. And again, there's guidelines on that as well. So we're going to start with a case. So you're in resus, the red phone rings, and you've got a pre-alert. So your pre-alert is that there's a 4-year-old child who's been playing in a cul-de-sac with other children and was hit by a car driving at around about 30 miles an hour, bounced off the front bumper and onto the curb. So what I want everyone to do is go to slido.com. Okay, so I'll give you a minute to do that, and there's a code there, and there'll be a couple of questions. So okay, is everybody on Slido now? Okay, so the first question, if you just go to the next slide, with the information you've received on the red call, what would you do? Would you do a full trauma series? So that's CT head, neck, chest, abdo, pelvis. Would you do a CT head within an hour, a CT head within 12 hours, or option 4, you don't know and you need more information? So I'm just going to have a quick look, and yeah, so everybody has said they don't know and they need more information, and that's exactly right, because you don't even have any obs on there. Okay, so if you go to the next slide, yeah. So then the child's now arrived in ED. So you assess the child and you find out a little bit more. The child never lost consciousness. There's been no seizures. You've had a look, you can't see any bruising. They're chatting, telling you what happened. And there's no other injuries either. However, it is a dangerous mechanism. So what are you going to do now? Are you going to, option 1, do a full trauma series? Option 2, proceed to a CT head? Or option 3, observe? So I'll just make that active. Okay. Very good. Usually the votes are always split, but today everyone said, 100% of you have said you'd like to observe. Very good. Okay. So we're just gonna, so that's really good. So everybody here knows exactly what you need to do. However, in other talks, it's been quite split in both of the questions. So I'm just gonna remind people what they might already know in terms of when you need to do a CT head within an hour. So NICE has clear recommendations on this. So if you suspect an NAI, you need to do CT head. If there was any seizures, but no history of epilepsy, again, you need to do CT head. And then looking at the GCS, so if the GCS was less than 15 or less than 14, so less than 15 for children under 1 or less than 14 for older children, you need to do CT head straight away. If after 2 hours they've been there and the GCS is less than 15, again, CT head. So in small children, you need to feel their fontanelle as well to see if it's tense, and then any suspected open or depressed skull fractures, as well as basal skull fractures or focal neurology. So in this case, the child didn't have any of those, so there's no need to do CT head in 1 hour at all. Yeah, and then again, don't forget children under 1, think about the size of their bruising, swelling or laceration. If it's over 5 centimetres, again, another indication for CT. Okay. And then there's further guidelines about when you need to do a CT later on, so not immediately, and these include certain risk factors, and you've got to have more than 1 risk factor. So if you've lost consciousness for over 5 minutes, any abnormal drowsiness, and 3 discrete episodes of vomiting. And our child had a dangerous mechanism of injury, but had nothing else. So you think, do I need to scan this child? Have they got anything else? No, they haven't. So at the moment, they don't need a scan. And then amnesia as well. So then if a child's got 1 risk factor like our child had, then you need to think about observing for a minimum of 4 hours, and that 4 hours is from the time of injury. So obviously when you do your histories, you need to know exactly when it happened. So some children you might actually see, and they've been in the emergency department for 4 hours or 5 hours, so they've already hit that time period, so that you can assess them and discharge at that point. Sometimes you might see them straight away, after an hour, so you might need to hold on to them for a bit longer. And again, if they develop any of the following, so vomiting, any episodes of abnormal drowsiness or GCS less than 15, then again, you need to consider doing a scan. If they don't have any of those and you've done a full primary survey to check there's no other injuries, then they can be discharged with the head injury advice leaflets that all of your hospitals should have. Okay, I think that's clear for most people because you're quite used to that. So this is just to remind everyone about the reason we're not just going to scan every single child that's just hit the head, because one, there's clear guidance about when we shouldn't be scanning children when we don't need to because of the radiation dose and the increased risk of cancer. So any CT imaging we do needs to be minimised and clinically justified using the ALARA principle. And then in 2016, NICE actually produced further guidance on major trauma, on assessing children and the initial management. So the East of England didn't actually adopt these guidelines till the end of 2017. So when you look at our audit later, you might notice some changes when the guidelines first came out and then what happened a bit later, but Leica's going to talk about that. Okay, so we've talked about the head. What about the C-spine? So again, we don't want to image the C-spine when we don't need to, because there's a very high risk of radiation to the thyroid gland. So again, the only time we really think about CTing the C-spine is if we're CTing the head and you've got an unconscious child, then you usually would do a CT C-spine at the time as well, because when someone's unconscious, you can't really assess or clinically clear the C-spine. So other things, again, GCS lesson 13, which means you can't assess the child properly, you might need to consider CT. Intubated child, obviously you can't assess the child, so again, CT. If the child's awake, then you look for focal neurology or paresthesia. So earlier when AJ was discussing his case and the child wasn't reacting to the cannulas, was that because there was focal neurology there, or was it because there's a low GCS? So again, if there's an awake child and they're talking to you, but then they've got numbness in their arms or they're not moving their arms, because even if they're on a trauma board, they can still squeeze your fingers. That's not going to cause them any damage. So that you should assess that as well. And then certain times, depending on the type of surgery, some surgeons would ask that we do some imaging of the C-spine. So again, you'd only do that after consultation with surgeons. And then if you've got a multi-trauma patient, you might think about doing the C-spine as well, depending on the mechanism of injury. And most of the time you'll do x-rays. And then when you do x-rays, you're going to use your 3 views. So you've got your odontoid peg, your AP and your lateral. And then if you've done your x-rays and they're technically quite difficult or inadequate, then, and you've got high suspicion, you do CT. If there's a significant bony injury, again, you do a CT as well. Everyone clear with those guidelines? Yeah. Okay, so I think I've already spoken about this apart from the dangerous mechanism. So just to remind everyone what a dangerous mechanism is. So an axial load to the head, that is a dangerous mechanism. And there was one over the weekend that had that dangerous mechanism that actually ended up needing an MRI, okay, but they'd had their initial imaging first. Again, a fall that's greater than a height of 1 meter or 5 stairs, that's a dangerous mechanism as well. And then the things that we see, rollover motor accidents, ejection from cars, and then bike collisions as well. A lot of the time, it's not always possible to as clinically clear the C-spine. So again, do the x-ray first, and then we can use Canada C-spine rules as well. Okay, is
so
everybody clear?
AJ's just got a question.
Oh, sorry, let me have a look. Yeah, AJ, do you want to speak? Because I didn't see your hand up.
No worries, Kuldeep. Just that one bit about if you're going to get a scan of the rest of the body, go ahead and get a CT C-spine as well. Do you agree with that?
So
I know it's on the guidelines. It's on the guidelines.
Generally, if you're doing a CT head and if you're doing a CT head, and then yes, but if you're doing a CT abdomen, I wouldn't necessarily do a CT C-spine. You know, if you're doing an abdomen pelvis because you're suspecting, you know, abdo injuries, then can I justify why someone's having a C-spine x-ray? Then I wouldn't know.
Yeah.
If the child is unconscious and I can't assess them, then yes, I would.
Yeah. Yeah. Okay. Good.
Does that answer your question? Or,
yeah, perfect. I was just like, because there's been a debate, as in like we've cleared the neck. But we need a head and an abdo. What do we do? You know, do we get a neck as well? Because we're like, okay, why not?
And do remember they're awake children as well. There's a big difference between awake and unconscious children. If they're unconscious, then obviously you can justify it because there's no way to clinically assess it or clear it. When they're awake, or if they walked in and they were, you know, moving everything, or you could clinically clear it, then no, I wouldn't. So it's just because remember that thyroid gland.
Yeah. Yes, exactly. That's what I was thinking, because in the case that I just mentioned before, we did a head and an abdo pelvis. We didn't do a neck because we cleared that and the child was awake. So that's why I asked that particular question right there.
Yeah. Great.
All right. Thank you.
No problem.
I think Hema's popped her hand up as well. I think this is a really interesting discussion.
Yeah.
Sorry, what I would definitely say is, if there was a spinal fracture somewhere else, and even if the child was awake, then yes, you could justify getting a CT of the C-spine. Otherwise, there is no harm in sending this child again, or kind of telling the radiologist, look, we are not sure what is happening here. Do you mind having a cursory look to see whether we need to include the neck as part of, before getting the child down? And yes, I would completely agree. There wouldn't be a knee-jerk reaction of, I would, you know, CT the whole child.
Yeah.
So, yeah.
Yeah, and a lot of the time, if you've got spinal fracture somewhere, you usually have it in 2 places. So, yeah, do think about that as well. Yeah, sorry, Ash, have you got a question?
I was just going to say, in terms of, with reference to the case that you were talking about, AJ, I think if you're scanning the head and you've got a, you know, what's recognized as a distracting injury in terms of significant intra-abdominal pain, I guess the question that would be going through my head, whether or not the child is moving, is have I really authentically been able to assess the C-spine? And I guess that's a question for the clinicians that are at the bedside. I wasn't there, but I think that's the question that I would have.
And don't forget, hyperflexion, hyperextension injuries as well can cause problems with children as well, and they might end up having MRIs. So it's all important to think about the mechanism as well. Okay, any other questions? Any other hands up? No, okay. Should we move on? So I think I'm going to hand over to Leica now, who's going to talk about the audit, and then we can pick up questions together as we go.
Yeah, so all this came on the back of an audit that myself, Rabia Yusuf, who's a consultant at Southend now in the emergency department, and Shruti Agrawal, who's a PICU consultant. So we looked at 5 years worth of data before and after the introduction of the guidelines, the introduction nationally, as well as the adoption by the East of England network. And we looked at about 300, almost 300 children, only with an injury severity score of over 8, so only the moderate and severe trauma cases. Yeah, so basically the children who were admitted from the region to the major trauma center. So the results were quite interesting. 241 patients had CT, and this was a total of 632 scans. And almost 20% of those scans did not comply with the guidance for irradiating children. And this actually affected a third of patients. And by far the majority of scans that were non-compliant were chest CTs, and then followed by abdo, pelvis, and head and neck. And if you look at we looked at the years as well, and as Kuldeep mentioned, at the end of 2017, East of England adopted the guidelines, and so there's a nice nadir demonstrated in 2018, but this started to climb again in 2019, and that's why we've spent the last year trying to re-educate various departments about when to CT children. So I think Kuldeep's already gone through this, but it's just about remembering the ALARA principles. So we had to think about why clinicians were, so the main aim was to look at clinician decision making, and why did they choose the CTs they did. And I think mainly because ED is led by adult physicians usually, and pediatric traumas are led by adult physicians. They're very used to doing a trauma series as an automatic reaction. You wouldn't think twice about putting an adult through a trauma series. And this was transferred to the pediatric protocol. But actually the guidance shows that, so as mentioned in the first case, mechanism alone is not an indication to do head and neck CT. You actually need another risk factor. And then for chest CTs, you would only do a chest CT if there was a penetrating injury, and not if, so you'd always do chest X-ray as first line. And indeed in our own audit, all the CTs that were done, none of them actually had a finding that required an intervention. So the majority were just things like pulmonary contusions, which are treated conservatively, and there was the odd tiny pneumothoraces. And then looking at the Abdomen Pelvis, the unconscious patient is a tricky one because you can't assess tenderness. So we did allow that as a justification for a CT Abdomen Pelvis. But usually you'd look at bruising, signs of hypovolemia, any distension, and that would indicate a CT. But otherwise you would do serial abdo examinations and look at the observations and trends of lactate and any HB drop. So just to mention that, yeah, we spent a lot of the last year looking at different departments. So this is why we've had quite a split results. We're dealing with a very highly qualified audience this today, but it's interesting. So the head and neck child at the start in case 1 was sent for full trauma. I think she was sent for a full trauma series actually. So it's just quite surprising that, you know, awake child who's chatting to you was sent for that. And yeah, there's quite a split in the region. This is just lifted from the NICE guidelines about using a chest X-ray as first line and not using CT. I hope you can see this, but so this is the TEMPO guidelines, the East of England Network trauma guidelines. Have developed this little stick man, and it just it's just a reminder of when to use it. Kind of signposts you to different guidance of when to CT. So head and neck, as you can see, they signpost you to the NICE head injury and C-spine imaging criteria. And as Kuldeep mentioned, if it doesn't meet NICE criteria, but even if you have a clinical suspicion of C-spine injury, you would do C-spine 3 C-spine X-rays rather than CT. And they actually even say that if that's inadequate, consider MRI and then CT if MRI is unavailable. We've talked about the chest, that you would use chest X-ray first. And in Abdomen Pelvis, you'd only use CT Abdomen Pelvis if there's lap belt injury, bruising, tenderness, distension, hypovolemia, or bleeding. And in brackets, this is not actually included in the guideline, but they're just ballparks figures about the irradiation dose. And you can see there's quite a stark contrast between, for example, CT Abdomen Pelvis is 4.5 years background radiation, but they're just ballpark figures. They're actually based on adult data, and we know that children are much more radiosensitive, and there have been a lot of changes over the years. So CT scanners use low dose radiation for children, lower dose radiation for children. But it's just to remind you that just because the child is going in for a CT head, don't just add on other CTs just because they're there, because it all adds up. So this is another case, just to test your knowledge again. Is a real case. So this is a 15-year-old.
We'll give you 5 more minutes, Leica.
Yeah, sure. So 15-year-old riding a bike with their friend. And so he just went up ahead with his friend, and the friend followed a few seconds behind. And he found the child next to the bike, awake but confused, with a broken helmet. And when the paramedics arrived, he vomited and had a seizure for 1 minute. By the time he came to ED, though, his airway was patent, he was awake, SATs were 98, there was no surgical emphysema or crepitus, no chest wall injury at all. He was slightly tachycardic, but his blood pressure was holding. Abdo was soft and non-tender, no bruising. But neurologically, his GCS was 14 because I think he was awake and following commands, but he was still confused, so he dropped 1 for verbal. But otherwise, his pupils were normal, and there were only superficial abrasions. But then he dropped his GCS at this point to 7. So if you can get the Slido up again, it's the same code. If you just go back to Slido and just choose what imaging you would do at this point. So CT head and neck only, a CT trauma series, CT head, neck, abdo, pelvis, leave the chest out, or no CTs and just X-ray relevant areas and observe. And cool, if you can just let me know when.
I'm just. I've got a couple of people. It's got 3 people, so a few more.
I think we've got 15 people on here, or maybe slightly less.
Yeah, we've had more responses before, so 4. Anyone else? So out of 4 people, oh, there's more now. Okay.
Let's just give maybe another 10. We're finishing on this case, so.
Yeah. So there's no more Slidos after this. This is the last one. Okay. So this is a split vote. So 60% of people have gone for CT head and neck. No one's gone for a full trauma CT. 20% have gone for CT head, neck, abdo, pelvis, and 20% have said no CTs, just X-rays and observe.
That's interesting. So I'll tell you what the hospital did. The local hospital, they intubated the patient naturally. Oh, sorry, I should have mentioned that they stabilized the patient first, and then you can choose your CTs options. But yeah, anyway, so they intubated the patient, neuroprotected, and they sent the child for a full trauma series. But interestingly, there were not much to report on terms of injury. He only had right-sided temporal contusions and only some pulmonary contusions and nothing else. So nothing that required intervention at all. There was a comment that the splenic images were non-diagnostic, and it was documented that this was discussed with the consultant who said it was a low index of suspicion, so not for repeat scan at this time. So there was no surgical emphysema, no penetrating injury, so why do a CT chest? So I'm glad that no one said to do a CT chest, so I think that point's clear. And this was just based on so it's just to illustrate the point, there was a large multi-center trial in Houston last year where they looked at 1,000 kids, over 1,000 kids who had pediatric blunt trauma. The chest X-ray, they all had a chest X-ray and an abnormal CT. And about 40% actually had a positive finding on the chest X-ray, and this correlated with abnormal CTs. But if you look at the right-hand side of this flow chart, this only changed about 5% of management in all the children. And this could be as simple as having an extra day's observation. So they did not think that this was warranted this was not significant enough to warrant CTing every child. And if you consider CT chest is about 3.5 years of background radiation compared to chest X-ray, which is only 3 days. So abdo pelvis in this child, so I think we would argue that that probably they should not have a CT abdo pelvis, because when they were assessed as awake, they didn't have any tenderness or bruising, and there was no sort of signs for an abdo pelvis. But I take on the point that because they're unconscious, it does muddy the waters a little bit. But this child had all these CTs, and this added up to about 10 years worth of background radiation. And head and neck, I think definitely actually they do need a CT head and neck, because this child had possible loss of consciousness. One a seizure, vomiting, mechanism of injury. There was enough to justify head and neck in that situation. However, this child probably had about 8 years worth more of radiation that could be clinically justified. So in summary, so chest X-ray is the first line in pediatric blunt trauma. I think everybody now has had that point drilled home with, and only do a CT chest if there's penetrating injury or positive findings on the chest X-ray. And mechanism alone does not warrant a CT head, neck, abdo, pelvis. And also think about when not to CT as well as when to CT, and just stop and consider whether trauma series is appropriate in all children. So if we have time, I don't know, it depends on Annika. I'm just curious to hear what people thought about the last case, because obviously there was a bit of a split. And also if there are any questions, please do ask them.
Yeah, I just want to also reiterate that even in an unconscious child, a chest X-ray is fine, because with an X-ray, chest X-ray, you'll be able to see if there's any pneumothorax, you'll be able to see if there's a hemothorax, you'll be able to see if the child's been intubated, you can see their tube position. Unless it's penetrating, they don't need a CT chest, even in an unconscious patient. Yeah, carry on, sorry.